So with this, we now move on to Dr. Manisha Agarwal, who will be talking on top three mistakes in diagnosis of uveitis. Manisha is from Shroff Charity Eye Hospital, and she's heading the vitreoretina and uvea services there.
So very good evening to all of you, and thank you, Rima. I would be speaking to you on the most common three mistakes that we make in the diagnosis of uveitis. So let us first know what three common mistakes. The first would be that we diagnose an infectious etiology as a non-infectious etiology. The second being that we diagnose it as one infection and it turns out to be another one. And the third one being, the slides are not moving. And the third one being where you have uveitis, which is actually masking an underlying etiology. So these are the three common mistakes that we are bound to make in our practice. Now let's take all these three mistakes by case examples. So first is diagnosing an infectious etiology which has been diagnosed as a non-infectious etiology. So this is a 68-year-old male patient, and he presents with sudden diminution of vision in the right eye 10 days back, now having a blurring of vision in the left eye for last 5 days. He has a history of paralysis of left side of face, hypertensive for last 6 years, and also has a history of CAD with a bypass surgery which was done way back in 2011 and stopped Ecosprin on his own 6 months back. He had been diagnosed as a case of a branch retinal artery occlusion in the right eye somewhere else and was then referred. Actually, the patient came on his own because he started now having a blurring of vision in the left eye. So if you see the right eye, the vision was as low as finger counting at 3 meters. There was ONH swelling. There was a retinal edema. So there was no doubt that we were dealing with a BRAO in the right eye. But what apparently the ophthalmologist had missed was an examination, a detailed examination of the left eye. A peripheral examination of the left eye is something that was missed out in this patient. The patient had a vision of 636 N36 in the left eye. You had an optic nerve head swelling, and the patient had this classical tongue-shaped peripheral lesions, which you can very well see in the peripheral fundus, very much suggestive of a viral retinitis. The patient underwent a whole gamut of investigations which very much confirmed the presence of a viral infection, and the patient was treated with oral valcyclovir and the Ecosprin was continued, and also with intravitreal antiviral injections. The patient was also started on oral steroids, and the risk of RD was explained. The patient at follow-up at 3 weeks, the both eyes had dropped to a vision of 3/60. We went ahead and we did a 360-degree laser to avoid a retinal detachment in the left eye. The follow-up at 2 months, the patient did not recover much vision in the left eye. So when we reviewed the literature, because it was a learning for us also, we found that vascular complications apparently have been reported with ARN, and BRAO has been described as a sign of ARN. A combined vascular occlusion at the initial presentation can subsequently develop ARN in the fellow eye. So here we had an elderly gentleman with a history of CAD diagnosed with BRAO in one eye and referred to the treating cardiologist. Viral retinitis in the retinal periphery of the other eye apparently was missed, and probably the prognosis in the left eye may have been better if it was managed on time. So we went ahead and published our experience in the form of a case report because it was very much a learning for us. The second mistake being diagnosing it as some other infection. So we have this young 18-year-old boy from Bihar with a gradual painless diminution of vision in the left eye for last 6 months, no significant systemic or a contact history, low socioeconomic status. The patient had this huge yellowish subretinal lesion in the macular area with subretinal fluid. And when we did a fundus fluorescein angiography, you found that there was a mottled hyperfluorescence which was seen within this area of the lesion. So the provisional diagnosis, of course, was a subretinal abscess, secondary to most common being tuberculosis, or to some other chronic infection like a fungal infection, and last but not the least, a lymphoproliferative disorder, which was the third on our differential diagnosis list. The patient underwent a baseline investigation where everything else was not really suggestive of any infection, except that the Mantoux was 0, and you don't expect the Mantoux to be 0 in a young child. The patient had a raised ESR, which just suggested that the patient had a chronic infection, and the Mantoux 0 probably because either the child was immunocompromised. So we referred this patient to a pediatrician who said that everything looks pretty okay, except that the patient was not vaccinated with BCG, the patient was mentally subnormal, and the clearance was taken for starting this patient on systemic steroids. So nothing was really conclusive. So what we did, we went ahead and we did a vitreous biopsy for this patient. The gram stain came out to be negative. There was no acid-fast bacilli, which was isolated. The PCR came out to be negative for MTB, and the culture report was awaited. Now, since this patient was from Bihar, he was not ready to stay back. So we started this patient on broad-spectrum antibiotic in the form of ofloxacin and steroids, and the patient went back. The patient did say that he had cough with expectoration. The sputum sample also was sent, and it came out to be having only a single acid-fast bacilli, and the physician was not really convinced to start ATT for a single bacilli. But to our utter surprise, when the culture report came, it showed Nocardia species. So here we were actually all doing our investigations, our clinical examination. We kept suspecting tuberculosis, but it came out to be a Nocardia infection. So apparently after this culture report, the MRI of the brain was done to rule out intracranial nocardiosis, and the patient was started on sulfamethoxazole and trimethoprim combination along with oral steroids. And the patient did show a very nice improvement. The vision improved to 618 and N12 with a complete regression of the subretinal fluid, and you also find that there's a regression of that yellowish lesion. So this was a rare entity, most commonly affects the choroid, and the spread is hematogenous, the nocardial infection, and the posterior pole is said to be most commonly affected, as the choroid is thicker with more dense capillaries at the posterior pole. Intracranial involvement is common, and it's very commonly confused with tuberculosis or a fungal infection. So again, we had a learning from this particular case, which we again published as an interesting case report. The last mistake can be that we are missing the underlying diagnosis under the cover of uveitis. Now this has been actually a very great learning for me, 45-year-old female patient with diminution of vision in both eyes for last 4 months and having no history of systemic illness. She was diagnosed to have VKH elsewhere and was already treated with IVMP, high dose of steroids were on, and she had also been put on methotrexate and now on azathioprine, still not responding. And that is why she came for a second opinion to us. There was no relevant past systemic history. So this is how her fundus of the right eye looked, where you had exudative retinal detachment with extensive subretinal gliotic bands. The vision was as low as 1/60, less than N36, with no evidence of inflammation, which probably could have been taken care by the high dose of steroids and immunosuppressants, which she was already on for last quite a few months. We could not find any retinal break, so obviously a rhegmatogenous RD was out of question. The left eye also had a very extensive exudative detachment, and the vision was 624 N18 in this eye. So when we evaluated her OCT, we found an evidence of PD, and we thought that, okay, fine, we now have a diagnosis of CSCR, which probably this patient is having because of the high oral dose of the steroids that she is on, and we were quite convinced about it. So we stopped all her medication, and she also gave us a very interesting history of alopecia being treated with minoxidil, which again is some causative agent for causing CSR. So we thought that we are quite bang on diagnosis, and we are dealing with a patient with chronic CSCR, and that was the diagnosis. So why did we hold the entire history of treatment against VKH? Because she was getting no response to steroids, including IVMP, which is very unlikely in an inflammatory pathology. Also, there was no response to any kind of an immunosuppressants, and she was already on 2 immunosuppressants. So this I've already told you. So we gave a trial of eplerenone, and we reviewed her in 2 weeks, but apparently there was absolutely no response to this treatment, and there was no change on the OCT findings. So we went back to the patient again. We took a detailed history again. She gave a history of small nodule in the right breast 2 years back, which was diagnosed to be benign. And since we were ourselves lost in the diagnosis, we thought, okay, let's start from here. We sent her back for a reevaluation of the breast lump. A physical examination by the oncologist was done, and she was found to have these nodules in both her breast, and she was advised all these gamut of investigations further, including a mammogram, an ultrasound guided biopsy, a PET scan, and an MRI brain. And to our utter shock, she was actually having breast carcinoma in both her breasts, and she was having metastasis involving all parts of her body, including spinal cord, bones, liver, brain. There was no part of the body which was left without the metastasis. Bilateral invasive ductal carcinoma of grade 3 of the breast was the diagnosis made on histopathology. And this patient apparently had a very short lifespan which was left. So just to conclude my talk, this is the patient. She underwent a surgical intervention for the exudative RD, and we were able to make this patient at least ambulatory to whatever lifespan was left for her. So the clinical pearls to learn from this case was that the patient was not responding to treatment, so it was time to revise your diagnosis. And that is where we have to restart by taking a detailed history, run through all the investigations, and take another opinion. We may always have something underlying which may be fatal if not detected on time, like this inpatient. So how to avoid these common mistakes? A careful history taking from the patient and detailed clinical examination often gives us a clue to the diagnosis. We must rule out an infectious etiology before diagnosing it as non-infectious and starting the patient on steroids and immunosuppressants. We should always be open to read up and revise our diagnosis. A regular follow-up is absolutely mandatory. And I would just take this opportunity to invite all of you to our forthcoming annual conference of Uvea Society of India, which is going to be held in Hyderabad on 14th, 15th, and 16th of October. The registration is already on, so please go ahead and take advantage of an early bird registration. And